Thank you, Mr. Chairman, ladies and gentlemen. So I was asked to talk about E-CPR, and discussing with Alain, we think that we have to talk also how to do that, but also who will do that. And perhaps thanks to the previous speakers, so I will probably go over quickly over some of my slides. I think to start with, it's interesting to read this editorial published in Resuscitations, where finally E-CPR is described as needed a very well-trained personnel. It's quite demanding for the team. It's quite expensive. There is not that much information regarding outcome, but in fact, the fact that we have a disposable, an extracorporeal membrane oxygenation device does not justify its use. So I'm going to try to show you that we have some data, at least to offer this technique to some of our patients. So I'm going to go over some of the questions that have been found interesting in this situation of E-CPR. So first is, why do we think that it could be useful for some patients to be started on E-CPR? We know that cardiac arrest is still a poor prognosis with a very low survival rate. There is quite a lot of room for improvement, and we need to find some techniques, treatments that will help our patients to survive. And finally, extracorporeal membrane oxygenation has been applied to intra-hospital cardiac arrest in the late 1970s without success, but at least it has been tried since already quite a number of years. And there are data in the literature showing that E-CPR can result in hemodynamic stabilizations and increase the rate of ROSC. So how does that work? Just to give you a quick overview, as you can see on this cartoon, there is in fact a combined blood flow from the native heart and from the extracorporeal circulations. This induces several effects, which can be good or bad. Regarding coronary perfusions, the extracorporeal circuit induces decreased preload for the left ventricle, decrease left ventricular end diastolic volume, decrease left ventricle end diastolic pressure, and so increase coronary perfusions. On the other hand, it can increase afterload, it can increase the left ventricle end diastolic pressure, increase the left ventricular work, and increase the risk of mitral regurgitation and pulmonary edema, so decreasing coronary perfusions. Regarding the blood flow for the patients, it's a combination of native heart and native cardiac output and blood flow generated by the extracorporeal circuit. So we can end up with a competitive flow from the native heart, which increase, as I said before, the left ventricle work. You can observe also a differential oxygenation between the upper body and lower part of the body, what we call Harlequin syndrome. We observe also most of the time at the early phase of the E-CPR decreased pulsatility, and this will increase the risk of thrombosis of the aortic root. On the other hand, the extracorporeal circulation will increase the total blood flow, will increase the oxygen supply to the body, at least to the lower part of the body, will increase the blood pressure, and will normalize PO2 and normalize PCO2 and pH. So some of these effects are probably useful in this situation of prolonged cardiac arrest. Just to remind or to show you for people who are not aware of this kind of situations, what we can end up with the ECMO flowing through the aorta, stopping around at the aortic arch, and finally the coronary vessel receiving bad blood, or at least a poor perfusion from the native heart. So why do we think that E-CPR could be useful for prolonged cardiac arrest or for cardiac arrest? There are some animal models, but we have also data on resuscitated patients which demonstrate that there is a a significant decrease in left ventricular function after prolonged cardiac arrest. In this study published recently, the author demonstrates that the left ventricular ejection fraction was depressed during at least 3 days before recovering. And during this early phase, what we call vascular and metabolic phase, E-CPR or prolonged cardiac support with extracorporeal circulation could be useful to help the heart and the patient. So I will go quickly over the inclusion and exclusion criteria as it has been already discussed in the 2 previous talks, just to mention that in some area, in some country, people use a cutoff for 75 years old to start E-CPR, which is quite old and which is not what we are used to in France, or at least in my unit. More interesting, as has been presented before, the time to start E-CPR is a critical issue, and in most of the protocol, it is recommended that this time was below 30 minutes. And there are, in fact, a lot of discussion regarding this time issue. For some people, 10 minutes is a good time frame. Why? Because it takes time to go from the site of the cardiac arrest to the coronary lab or to the emergency department or to the OR. So some people recommend to start from the site at 10 minutes, which is probably a little earlier, hearing what have been said in the previous talk. Most of the study recommend 30 minutes to start with E-CPR or thinking to leave the site to go for CPR. There is some data showing that the increased time in pre-hospital increase the risk of adverse outcome. Regarding the usefulness of E-CPR on ROSC, this has been demonstrated, or at least is reported by Chen in a study, an analysis of intra-hospital cardiac arrest over 3 years, cardiac arrest from cardiac origin. This author have compared 130 conventional CPR to almost 60 extracorporeal CPR. And what is demonstrated on this slide is that after 30 minutes, there is a huge difference between the ROSC number obtained through CPR versus E-CPR, which is one of the reasons to advocate the use of E-CPR in this time frame. And this is almost the same, and this slide has already been discussed in out-of-hospital cardiac arrest. Exclusion criteria are very important if we don't want to face either a high number of E-CPR which end up with death, or if we are going to increase the burden on our team. It's quite important to make sure that these exclusion criteria are looked for, and as it has been described, pulseless electrical activity and asystole are not useful or are not good candidates for E-CPR. So regarding wear and team, it's quite interesting. There has published in the literature from the Paris group the use of E-CPR and the insertion of cannula on site with interest to decrease the transfer time before starting E-CPR. This study did show the feasibility of this strategy, but it's quite demanding for the team to be ready to go on site and start E-CPR. But in a real life, it's not really done most of the time, and as has been also described previously, most of the team use medical device to transfer the patient to the hospital to start E-CPR. Some of the patients has been also transferred to cath lab under mechanical device. The mechanical device allows to perform E-CPR while the patient is still resuscitated, and finally the team can spend time in other actions. So who can do that, and where do we have to do that? In the literature, it's not that specific. In a recent meta-analysis published in 2017, there is no mention of where this E-CPR has to be performed. You can find in the literature E-CPR started in ED, in ICU, in the OR, or in the cath lab. So, for example, in Australia, at the Alfred Hospital, the CHEER trials is running by the critical care physicians, which directly go to the emergency department and start E-CPR for out-hospital cardiac arrest patients. There is a recent survey of E-CPR in the United States. And in the questionnaire, they ask who does the E-CPR and who is part of the member of the team. And you can see that there are huge differences, and there is no real team dedicated according to this study. Most of the time, perfusionists are involved, and pharmacists. But finally, cardiothoracic surgeons, emergency physician, cardiology, interventional cardiology, vascular surgeons. As you can see, there are a huge body of people who can be involved in E-CPR, and probably the most important thing is that we need a trained team. And E-CPR in this study was practiced in ED all over the United States, and you can see that on this cartoon, the dot represents the ED CPR, where there are no programs started before. That means that in this ED department, there is no ongoing program, which is one of the concerns in terms of results, of good results. Regarding the time frame, there is also some concern regarding the night shift and the day shift, the weekend, the business hours, and the weekend days. For example, in the Montreal program, outside business hours, you have to discuss with the surgical staff, because it's not that easy to mobilize a team to start an E-CPR in a short time frame. And it's the same thing in the Prague protocol. People are included between 8 a.m. and 4 p.m., meaning that it's always a real concern to be able to mobilize all the team needed to start E-CPR. Regarding equipment, fortunately, this has changed quite a lot since the first heart-lung membrane. And you can see that when the patient is stabilized, it doesn't look like so bad. And finally, it's quite convenient to have these patients on extracorporeal circulations. Regarding venous access and arterial access, there are several issues. Ultrasound guidance is a requisite. It can be done surgically, percutaneously, or with a cut down and a direct punction of the vessel with the Seldinger techniques. The size of the cannula is variable, usually between 5 and 15 French for the arterial side and 21 and 27 French for the venous side. And access usually is the femoral side, but some of the patients did require, not for out-of-hospital cardiac arrest, most of the time for surgical arrest patients, a central access. You have to make sure that the cannula is well located, and you need ultrasound. You can end up with left ventricular failure, and it needs also to be into account. There are a lot of data talking about where you can do that, which number of center you require, and this study demonstrates that at least for VA ECMO and cardiac support, there is a difference between high number of cases per year comparing to low number of cases per year, with a better outcome in high volume centers. So this centers has to be integrated in a plan and in a program, and it can be done in all over the place. Patient who is on CPR need to have an NGO, and 87% of the patients with prolonged CPR did have coronary obstruction. Just to the quality of CPR need to have a short time before extracorporeal life support, using of therapeutic hypothermia, avoid hyperoxemia and anoxia. Hypocapnia with alkalosis may be more dangerous than hypercapnia, and optimal mean arterial pressure is not clear. I will go quickly over that. Just to use this slide as the conclusions, which is a recommendation published in the circulation in 2015, which recommends that E-CPR may be considered for select patients for whom suspected etiology of cardiac arrest is reversible. And as has been said in the previous, with the previous talk, the age of the patients and the fact that this patient has been as a witness and started CPR is factors of good prognosis. Thank you.